Okay, I think that the master of the ceremony, Yves Louvard, is still sipping his coffee, but I hope that he will come soon to help me in the chairmanship of this session. We have a remarkable panel, but you could see on your program their name and where they are coming from. I'm Patrick Serruys. I think this session is quite important for the future of the bifurcation. And it's a very remote session in the sense that Yoshinobu is there. Carlo Collet has moved to the United States. He's now in the CRF and in St. Francis Hospital. Filippo Cademartiri has sent a video. John from our institution is very busy these days, so we said you could stay in Galway and send a video, and Dr. Tu is here. So, in the absence of Yves Louvard, we are going to start. And I'm going to do an introduction. I will be no question after this introduction. Later on, we can have a question on that topic, but I'll try to use the 12 minutes allocated. So if I may have the first slide, thank you very much. So introduction is 3 anecdotes on left main bifurcation and CCTA, the surgical, the interventionist, and the preventionist view. Let's start by the main stem bifurcation to be treated by pharma. That has been reported by my colleague Prudvi Revaya in the European Heart Journal. This is a 69-year-old woman, hypertensive, non-smoker, hypothyroidism, no previous cardiac history, atypical chest pain. You do a multi-slice CT scan and you see at the end of the left main a soft plaque, which is characteristic for a napkin ring sign with remodeling and low attenuation. And in terms of tissue, you could see that it's lipidic, lipid-rich, is basically what we call napkin ring, and you see the histopathology of that. We did, on top of that, the perivascular fat attenuation. If you make more sophisticated analysis, you see that the wall shear stress is still below the critical level, but the actual plaque stress is clearly above the normal. So if you look at the characteristic, you have a lesion length of 16 millimeters, you have a napkin ring, you have a remodeling index, and you have a low attenuation, all bad sign. And in terms of adverse hemodynamic parameter, you just have the delta FFR. I consider in detail not severe, but after the lecture of Co, it became severe. And then you have this high actual plaque stress. Now, initially, the LDL is 214. With rosuvastatin and ezetimibe, you go back to 85 milligram. And if you had the monoclonal antibody against PCSK9, you go down to 10 milligram per deciliter. And you could see that this napkin ring doesn't get calcified. And as a matter of fact, I suspect that in the future, you have an improvement of the FFRct from 0.77 to 0.84. And I think that in the future, you will have what we call the donut that we just have described with Filippo in the European Heart Journal Imaging, which is on photocounting a low attenuation completely surrounded by calcium. That's a new phenotype of lesion. Main stem bifurcation to be treated by PCR, also reported in the syntax tree with Collet and Yoshinobu. This is an 81-year-old male, crescendo effort angina, no risk factor, no prior medical history, and you could see immediately on the MPI a severe calcification of the distal part of the left main and further at the level of the second diagonal. And of course, the ostium is fine with 16 millimeters square, but distally it's an MLA of 3.34 with a diameter stenosis of 71%. And there is an involvement of the LED and there is an involvement of the LCIC, and of course the FFRct is very, very low. So what you do in this case, you consult the Syntax 2020 on our smartphone that predict 5 years MACE and 10 years mortality. And you see that in this case, there is no difference between PCI and CABG, so we decide to go for PCI. And this is a live case in PCR 2023, Galway, Toulouse. First, we select the guiding catheter after measurement of the sinus valsalva with a diameter of 2.88. We took an ABU with a band 3. Then, considering the circular calcium in the mainstem, immediately we went for lithotripsy 10 times and then put the stent. In terms of angiography, you know that for the intubation, we need an LAO 20 degrees and a cranial 30 degrees. We know that for the most angulated appearance of the left main, the LAO 50 and the caudal 35 was the good one. And then you can do a virtual treatment by planner, predicting the flow. You see that everything which was red is now blue or green. Only a secondary division of the second diagonal is still red. And we use a 28 millimeter stent with a diameter of 3 and a pot of 4.5. Now you could see the angiographic result, which is good. You could see the OCT, which is impeccable with apposition everywhere despite all this calcium. And then if you look 2 years later, despite the blooming effect of the calcium and the stent, you could see that you have an area of 7.57 distal in the mainstem. And I have to tell you that the world is changing. The photo counting can visualize the struts with a resolution of 111 micron, allowing a 3D reconstruction of the stent and visualization of the metallic carina of the two-stent bifurcation. I'm finishing about the main stem bifurcation to be treated by CABG. You see in this case, also 81 years old, also class 3, no history of previous myocardial infarction, and you see immediately a complex trifurcation with a lot of calcium. Now, today, we like to work more and more with the extended reality. You see the heart team. We have the hologram hovering over the table. You can recognize Professor Onuma and myself. And the surgeon is showing him what he is going to do. He sees that in his goggle. We see that on the screen. And at the bottom, using the goggle, I'm measuring the bypass length that we need in this patient. Now, this is what I see in my goggles. I see right coronary artery, conus branch, ventricular branch. You will see the LED. There is a severe lesion there in the LED with calcification. There is 2 lesions in the intermediate and some lesion that you could see behind in the obtuse marginal. If you remove the conus of the pulmonary, then you can appreciate the mainstem highly calcified with involvement of the LED and involvement of the circumflex. So what we did in this patient is that, again, we look at multiplanar reconstruction. That's the most conventional. You don't need the hologram. You see in this right 3 lesions, The first two have some limited calcium. I don't like the third one. The third one is clearly with some lipid, is not circular, and you could see that the FFRct is 0.8, so the surgeon was asking, should I graft this right coronary artery with an FFR of 0.8? And you see multiple bifurcations, so he had some doubt about where to put the graft. The trifurcation that you could see is complex, and the end of the main stem is very diseased. You see that calcium and severe narrowing in the LED, the ostium of the circumflex also. The LED is almost a total occlusion. There are two lesions in the intermediate, but again, you could see the main stem calcification, then the intermediate. And the ostium of the circumflex is also involved, going to the obtuse marginal, which is also narrow. So again, we consult on the smartphone the Syntax 2020, and this time, same age, 81 years old than the previous patient, the absolute risk difference is 19.5. So the patient went to surgery. And after surgery, we have repeat the multi-slide CT scan in this 114 patient published in the European Heart Journal. And you could see the lemma, which is going on the LED with perfect connection with the LED. You see the bypass graft saphenous going to the obtuse marginal, but I will concentrate on the saphenous vein graft, which is going to the right coronary artery, but very high. You see the connection is even before a modest narrowing of this vessel. So this is the functional result, saphenous vein graft implanted very high, a little before a lesion. The FFRct went from 0.8 to 0.88, that's good news. The lemma is impeccable. I mean, the FFRct 0.50 went to 0.91, and the saphenous vein graft on this miserable obtuse marginal with multiple narrowing, the surgeon has to go very distal. Nevertheless, an improvement from 0.59 to 0.79. You could do a 3D printing after and look if you detach the rima from the wall, it's no longer tortuous, and you could potentially, the surgeon could have used the rima to revascularize the right coronary artery. If I move and rotate it, you could see that you see the saphenous vein graft on the right coronary artery, and you see the surgeon could have done that. So this is a kind of augmented reality after the treatment. I have to come to the conclusion, my time is over. Left main, non-invasive CCTA, imaging with hologram, and decision-making is a good ménage à trois. And I think that in the future, you will see more and more and more of this type of medicine. Thank you. Yves was the co-chairman now, but okay, you will show up at some point. I think that we can have one or two questions because I was on time. So any question, otherwise later on we will have some questions.
Just a really quick one, because that first case you showed, there's the CT-FFR 0.77. So in some institutions, because it's the left main, the surgeon would have said, I will operate. And then the patient gets some medications, and actually the left main becomes non-significant, and then the bypass goes down, and they have actually done sham bypass operation. I think it's a really illustrative case. I mean, that these patients perhaps should be tried on medical therapy with repeat CT scan and then decide, do they need PCIO cabbage?
Yeah, I think that you have to go one by one. I mean, just to repeat myself, the first one, the lady with this non-obtuse stenotic lesion, 27%, you're not going to do a PCI on that if you can master with medication. And you know, to go from that level of LDL, which was above 200 to 10 milligram, and you know, there are now cardiologists who have an LDL of 7 milligram. I will not tell you the name, but that's really a powerful medication. And you see the soft lesion with attenuation literally disappearing of getting calcified. The second case was a good case, a good selection. There's no doubt about that. And the follow-up is excellent. The patient is totally asymptomatic. It was class 3. The last case, I think, is very dangerous for the interventional cardiologist with the trifurcation, all this calcium, and all the lesion. I'm not so impressed by the work of the surgeon. I think that we have been working in this trial with John Puskas, and John Puskas do 5 arterial connections. He connects the rima with the radial, and he connects 2 radial on the lima. So he has 5 arterialized connections, all of pump. I don't know many surgeons in the world who are doing that, but pay attention to the surgeon. They are damn good. Some of them are very good. Yeah, Ben.
Yeah, Patrick, congratulations to this fantastic overview. What would you say for the future cooperation between interventional cardiologists and radiologists? Because at least in our center, we have 2 photon count CTs, and the cooperation is still not ongoing.
I don't know. It's a classic issue for the last 30 years. I mean, when I came to the Thorax Center in 1976, there was already a heart team. It has always been a key point. Polygonals want to work with the surgeon. He has a surgeon and an engineer, nothing else. No internal medicine and no radiology. We did everything by ourselves, okay? Just that mentality of our team was very vivid in the Thorax Center. The trial that we have done was every Thursday with United States and with Europe, with radiologists and with surgeons, a heart team by Zoom, showing the kind of things that I have shown, you know, the multiplanar moving and so. And the surgeon almost forgot that this still frame, which is moving, but and seen from all the angles. And it was a very pleasant relationship. The radiologist was useful, the surgeon was useful. Don't forget that all these patients has been operated without cineangiography, 114. And the anastomose patency that we have published in the European Heart Journal last year was 93% at 30 days. All of them were controlled by multi-slide CT scan. I think it's a very high level of medicine, but I'm sure that within 5-10 years, you will be there, for sure. Okay, I think we have to move.
Sorry about that.
How was the coffee?
No, it was water only. So the second lecture is FFRct, QFR, and Murray-based FFR is a disease, a non-disease left-made by Yoshinobu. So very interesting from my point of view.
Yes, yeah. Thank you for the introduction. So my topic is the comparison of FFRct, QFR, and Murray-based FFR in bifurcation points. Actually, this is the update from the presentation we made last year. Last year, we have demonstrated that in using the QFR 2.1, in the 3 most proximal bifurcations, the values were higher than FFRct and MuFR. And we just published this data in the, one of the journals, so you can really see that. I will come back on this same data later on, but just to see that in the first side branch point, second side branch point, third side branch point, the QFR value is somewhat higher than the FFRct or MuFR. If you go to the distal, there's no difference. So the new version of the MEDIS QFR 3.1 has been recently developed, and they added automatic adjustment of the reference line at bifurcation point according to the bifurcation law. Therefore, some of the limitation we observed in the previous version is overcome. The study aimed to investigate the correlation and agreement between the FFRct, MUFR, and the QFR 3.1 at the consecutive bifurcation points. So the methodology was the same like last year. We used the data from the fast track CABG study in patients with the 3-vessel disease or left main disease. All patients underwent the CT angiography or invasive angiography. FFRct was calculated by the heart flow, MUFR was done by the pulse, and QFR 3.1 was used for the QFR calculation. FFR values were calculated at sequential side branch points with all 3 softwares by 3 independent analysts. All side branch points were marked by a blinded matcher after co-registration of CT and the fluoroscopic angiographic view, and FFRct was recorded in the main branch just after the bifurcation, just after the side branch. So the physiological principle for calculation of the image-based FFR is shown in this slide. Heart flow FFRct is based on the coronary CT angiography. There is a full 3-dimensional CFT modeling available by using the parallel supercomputer. You have to send the data to California, but the result will come back very quickly. And this is a full modeling of the coronary angiography, coronary structure in 3 dimensions, and all side branch were reconstructed. MEDIS QFR version 3.1 using the 2 projection of angiography. Now they have the automatic detection of side branches in a vessel with a diameter of equal or greater than 1.5 millimeter, and they use the Lanz-Gould equation. Pulse QFR is based on the 1 projection using a Murray's law for the calculation of reference diameter in the bifurcation, and side branches were automatically recognized by software. So these are the flowchart of this analysis. We have 266 vessels by excluding some of the difficult case technically. We had 199 vessels analyzable for FFRct, QFR, and MUQFR. So these are the actual assessment. On the left side, you see the actual MPR of the CT. FFRct provides the 3D modeling. You can change the position or change the angulation of this 3D reconstruction of coronary trees. You can also match the projection exactly with the angiography. You could see that MEDIS QFR use 2 projections of the angiography. Sorry, I think the video is not moving, but Pulse used only 1 projection. So the 3D is reconstructed with the MEDIS 3.1 using 2 projections. Yes, thank you. So, so this is the actual how we measure the side branch points, the FFR in each modality of the imaging, FFRct, FFRct was reconstructed. We recognized each side branch point and measure the FFR just after the side branch using all the reconstructed side branch in the CT angiography. Then you have the angiography. We match the projection, so the CT and angiography is at exactly same projection. You see the same side branch also recognized on invasive angiography, and using these small or large side branches, we measure the QFR value along this main branch. Also the same was done by the Pulse software. And we also had the pullback curve of the FFR based on the angiography or the CT. So these are the correlation at each bifurcation point. There is a majority of them are true positive or the concordance, but there is also the discordance cases observed between the FFRct and QFR 3.1 or FFRct and MUFR. This is the result from the last year. So using the QFR 2.1, just to repeat what I have shown in the second slide, you can see that at first side branch, second side branch, third side branch, and fourth side branch, the QFR value, which is in green, is higher than the FFRct, which is in red, and mu-FR, which is in blue. So at first side branch, the QFR value was 0.97 in comparison with the FFRct value of 0.94 or the mu-FR value of 0.94. So in the proximal part of the vessel, QFR is producing higher value in comparison with the FFRct and mu-FR. But if you go to the fifth side branch or the more distal, this difference disappears. So in the end, if you measure the vessel QFR in the end of the vessel, most likely those three are matching. But if you look at the pullback curve, in the beginning of the pullback curve, the QFR 2.1 is somewhat higher than the other two modalities of the imaging. So using the new software, we observe that mean value of the FFR at first side branch, second side branch, third side branch become very close. So now the value is 0.94 for the FFRct, 0.95 for the QFR 3.1, 0.94 for the mu-FR. So the at side branch, first side branch, the value is very close. Although there was some statistical difference if you do the paired analysis between the FFRct and the QFR or QFR versus the mu-FR. But also this statistical difference disappeared after the third side branch. So third, fourth, fifth, or the distal side branches, there's no difference between these three modalities of the imaging. This is the division of the left main, diagonal, obtuse marginal, etc. So using the previous version of the QFR, we saw that the QFR value is higher than the other two in the left main, obtuse marginal 1, and right coronary artery bifurcation between the segment 4 and segment 16. But in the QFR 3.1, this difference disappeared, except for the left main, which has a slightly higher value with the QFR 3.1, 0.94, in comparison with the FFRct 0.92. On average, the mu-FR is the same value, 0.94, but still the statistical significance observed if you do the paired analysis. We also look into the PPGI as exploratory analysis using the pullback curve of this three image-based FFR. We could see that the previous version, last year we are somewhat surprised to see that the distribution is somewhat very different with the three softwares. But using the new version of the QFR 3.1, we see that the distribution is a little bit similar between the MEDIS and PULSE based on the angiography, although there's still some difference between the FFRct and the other two modality of the image-based FFR. So this is a comparison of the PPGI and DFFR-DS. The PPGI looks somewhat more higher with the QFR using the previous version, and also the DFFR-DS was very different if you compare that with the QFR 2.1 and the FFRct and mu-FR. But using the new software, looks like the PPGI is somewhat similar amongst these three modalities, although there is still difference observed between the FFRct and mu-FR. DFFR-DS is quite different amongst these three modalities of the image-based FFR. So this part, I think, should be further investigated or validated using the invasive FFR pullback. So as a summary, in this severely diseased population with the three-vessel disease or the left main, previously we have shown that QFR 2.1 values were consistently higher than FFRct at the proximal point, bifurcation point number 1, number 2, number 3, and number 4. But with the updated algorithm using the bifurcation law, QFR 3.1 values aligned more closely with the FFRct. In paired analysis, QFR 3.1 remained still higher than FFRct at the first and second level side branches, but the mean value were very close. At specific bifurcation site, QFR 3.1 and FFRct were more or less concordant or aligned, except for the left main, where the QFR 3.1 is still higher than FFRct value. So these findings highlight the importance of implementing the fractal or bifurcation laws for the image-based FFR assessment in bifurcation, especially when the software is used for the planning of the procedure. And DFFR TS values still differed across the three modalities, warranting the further investigation and validation using the invasive FFR pullback. Thank you for attention.
Thank you, Yoshi. I mean, question of the audience. A general comment that I can do is that one of the most exciting activity now in the core lab is the human being teaching the machine learning how the machine learning should do it. And it's a process of iteration up to the point that the machine learning do better than the human being. I like that very much. I mean, I didn't believe that I would do that at the end of my career, but it's really very exciting. For instance, just 2 days ago, we discovered that some side branches are not automatically detected. And then you have to teach again that the machine learning that it should also take the big septal branch and not only the diagonal. Now, that's obvious, but that can make the small difference between the surrogate, which is the QFFR, and the real things, which is the FFR, because there is no doubt that there have been a sur-evaluation of the QFR versus the real thing. We are now, I think, more realistic, but I must say that the improvement of the machine learning, and later on we will have Dr. Tu to tell us about that, is making big progress. And I think we're getting close to the reality, yeah? Any question from the audience? I think you have, Dr. Tu and Francesco. Yeah. Dr. Tu first and Francesco second. No, okay, you reverse.
Microphone before, so. Why for the micro-CT did you use the single view FFR, mu-FR? Because it is also possible with this device to have the three-dimensional reconstruction and an FFR that is based on two different images.
Yes, I think maybe Samben can answer the question very well, but maybe just my view that sometimes in these complex coronary anatomies, it's challenging to have a too good angiographic view demonstrating all the sequential lesions. Therefore, in this analysis, we decided to use the one projection where the lesions are more or less visible in a sequential way. So maybe something can also comment on.
Before the answer of Dr. Tu, Yoshi, you should say that it's quite amazing that when we look at the area under the curve for two view versus one view with your system, the one view was superior to the two view. Yes. I think that the combination of two view is somewhat a confounding factors. And we are working now, you do the angiography, and up to 15, 20, sometimes 30% of these angiography cannot be used for the QFR because they are not perfect. And we are developing now a machine learning which would say to the cardiologist, this is not good, this is not good, this is not good. First, your catheter is not coaxial and intubate. 2, your injection is not brisk. 3, there is overlap. 4, and so on, so that you will repeat the things in a better position. I think
before he
Dr.
can answer
Tu.
also to this aspect. No, so don't you think that since we are going to use more and more these FFR that are derived on imaging, don't you think that there should be an alarm by the machine saying that the value that has been generated is being based on some concerned regarding the incidents, the quality of the reconstruction, and so on. Because if we look at the future, when we will use this regularly in the cath lab, and you recognize in the cath lab, in the core laboratory, the fact that sometimes you need to adjust, you have to do something. It is extremely important that there should be a step where the machine says, okay, this is good, this is enough.
Dr. Tu, yeah?
Maybe I can make a comment to your question. I think in theory, if we add more view, in theory it's better. But in practice, this is not what we observe. Because if you add a second view there, especially for complex bifurcation lesion, sometimes the second view is suboptimal compared to the first view. So you actually compromise the reconstruction. So this is what we observe very frequently. So in our practice in China now, that we usually start with the best view to do a single view, and only when you see that in the second view, if the second view is a good view, and then the second view, the narrowing of the lumen the lesion is very much different from the first view, then we include the second view in the 3D reconstruction. So about 95% of them, you don't need a second view. That's what we observed here. I want to also make one comment to your presentation there. So actually the software for MUFR from post-medical, the Serruys detection, is not detecting 1.8, actually above 1.0. It can automatically detect the Serruys. There's one comment. Second, I want to ask, sorry, if I have time or not.
You will speak about your practice in China at the end, but now we have to move to Carlos Collet.
Can I just ask another question very quickly?
Carlos, no, we don't have time. We'll discuss a bit later if you... So we'll have a video transmission by Carlos Collet. Lessons learned from P4 in bifurcation lesions. What is P4? We'll discover
First of all, I would like to thank you for the invitation and for the fact that for the second year in a row in the EBC, we have included a chapter on the use of CT. And I believe that it's a field that's going to grow exponentially over the last couple of years. But I think in bifurcation lesions is going to be essential. And I'm going to elaborate on that, on what we have learned in the trial while conducting the trial about bifurcation lesions. My name is Carlos Collet, and I'm affiliated to the Cardiovascular Research Foundation here in New York. And I also work at the Cardiovascular Center, ALS, in Belgium. So I think to start with, we need to understand that the practice, which is limited to only clinical and geographic characteristics, is going to miss two important things about coronary arteries that basically drive treatment decisions, which are the understanding of the plaque in terms of the composition of the plaque, of the characteristics of that plaque, of the extension of atherosclerosis, and the physiology linked to the plaque. And we are moving from this concept of vessel physiology to lesion physiology, which I think is the one that's going to prevail over the next decade. And no surprise, CT has the capacity to basically integrate all this in a simple reconstruction, which is in 3 dimensions, and allows to understand the morphology of the coronary artery disease in a way that has been unprecedented until now. There is a case of the trial with a double bifurcation, mild lesion in the proxial AD, severe lesion in the bifurcation with the first diagonal branch. You see not only the calcium, you don't see only the anatomy, you understand the bifurcation angle, you understand the presence of disease, and you understand the location of the calcium. In addition to that, CT is able to provide us with a quantification of the vessel-specific mass, which again, in bifurcation lesions, helps a lot understanding the risk or the mass obtained by the side branch, and that, of course, as you know, may kind of influence treatment decisions. And now imagine that next to that, you have basically a complete map of physiology, both understanding the presence of significant lesions, in other words, FFR less or more than 0.8, but also understanding where are the translesional pressure gradients. That's key. That's the key point that we have understood from physiology. And then again, understanding the presence of diffuse disease. And having all this combined with of course, the clinical characteristics, the complaints of the patient, and of course the angiogram, I think it's going to have a big potential to basically improve interventions. And not a surprise, you can also then now understand whether provisional in this case, so how would that resolve, considering that side branch, which we're leaving ischemic, has a mass of about 12%. So imagine having this information in every single case, and that's where we're heading to. And of course, this is a case for two-stent bifurcation because you don't want to leave 12% of the myocardial mass severely ischemic. So these are the details that this type of reconstructions actually offer. And this is one of the software we have used in the trial, which basically quantifies the mass by every single vessel. You can click in any point of the tree. This is a fully automatic. This is actually real time. So you basically put a sit point, and in a matter of, you'll see, seconds, you get how much is the side branch in that particular diagonal. And then, of course, that informs about the myocardium at risk. Now, we analyze all the branches from more than 1,000 patients in the trial. And this is what we found. Not surprisingly, the mean or the median mass subtended by the LAD is about 43%, no surprise. Circumflex and right were similar to each other, with a little more left ventricular mass subtended by the cir compared to the right. Now, what is surprising is the graph on the right. Here we have the distribution of the first septal, the first diagonal, and the first obtuse marginal, which are basically the ones that drive the major bifurcations that are not related to left main. And we see that the first septal, subtends the same mass than the diagonal and than the marginal. And that, you can imagine that I didn't know that when I saw these results. I was surprised by the fact that we never protect septals. And we also know that when you lose a septal, that's a big problem. The patients will become very symptomatic and sometimes leads to big complications. And then we try to analyze now quantitatively, measuring the grams, each of the branches of the coronary tree. This is going to be published very soon by one of our fellows, showing the different masses. And here there are two informations. Of course, there is the median mass of each of the side branches, but it's also the distribution. And you see, for example, how the distribution of the septal is quite narrow, meaning that most of the septals subtend that. But when you look at the first margin, you see how variable this is. It can go from 0 to almost 40% of the mass. So again, we are in a moment where this concept of personalization of treatment is down to this point, to understand patient specifically what is the mass subtended by each of the branches. Now, I have a test here for the club. It's a test for the EBC test, number one, and I think Goran, Yves, and all the colleagues are there. I want you to look at this angiogram. And there are two big, let's focus on the diagonals. Diagonal 1 and diagonal 2. And I'm going to play it here still. Which amount of mass do you think that each of these diagonals subtend? Is the first more than the second? I let you think about it. Well, I give you the results. The second diagonal has almost twice the mass of the first diagonal. And this is, again, not apparent when you look at the angiogram. And let's do another test. If you got it right, you might be feeling good. If you didn't get it right, let's look for the second one. This is another case. It's a case that we did in Alison before. We were thinking, okay, which of these branches are we going to protect? Both look fairly kind of 90 degrees. The first one has some disease in the ostium, but let's think about mass only. Which of these two diagonals do you think has higher mass? This is the answer. The first diagonal, again, almost double. And, every time I know the results because I did the slides, but when you think about this, you say, well, it's quite difficult angiographically to really get to this precision. And again, this drive, of course, for example, protection or et cetera, or whatever you want to do. Now, the second big point that we have learned from P4 is regarding the distribution of the calcium. And When you look at a bifurcation in general terms, you can think about the angle of the bifurcations, you can think about the main vessel, this little main branch and the side branch, and you can assess that differently. You can also understand the plaque in 3D. But one of the things that we have learned is that understanding the position of the calcium with CT is extremely important. The reason being that when you have calcium contralateral to the side branch, as in this case, look at this case, this is kind of a saddle calcified plaque on top of this LAD and diagonal. And what happens is that when you place a stent and you don't modify the calcium, because honestly, it doesn't look so bad in terms of severity, but look what happened. This is a case, and we had acute side branch occlusion, and it was not because there was a problem with the side branch, it was basically the stent, the calcium in the contralateral side of that diagonal push or deform the stent, producing basically a carina shift towards the other calcified plaque, and that resulted in a side branch occlusion, which we have to balloon again, suboptimal, in my view, calcium preparation. So the capacity to look at calcium in 3D, I think it's going to be essential to really plan a bifurcation PCI. And the reason for this is basically that when we inflate balloons at the level of calcified lesions, the vessel will grow towards the least resistant part of the vessel, which is basically the non-calcified segment. So this is one of the mechanisms that explain all these things that I showed before. And finally, the last point that I think triggered my interest, and I think I'm a believer, or I firmly believe that physiology is going to be at the core of all decisions in the future for a number of reasons. But in bifurcation lesions, when you're going to engage in procedures that will require two stents, or these are procedures that are longer, you have the chances of having complications are higher, and of course, the durability of these results are lower. You have to be sure that you're offering a benefit to the patient. And the way that we kind of predict that in advance is by looking at the distribution of pressure loss. This is what we call the pullback pressure gradient, which is a number that basically quantifies this particular issue. And you see here that focal lesions with high translational pressure gradients are focal and close to 1, whether these diffuse pressure losses are basically a lower PPGs. Now, why is this important? I'll show you this bifurcation. This bifurcation, again, you see on the left side, the geometry without the calcified plaque. On the right side, the geometry with the calcified plaque. You see the narrow angle between the LAD and the diagonal. And what we start looking at it is, as I showed before, the calcium in 3D. And I'm going to let this video play because it's an enormous opportunity to understand calcium in a complete different way. You can basically zoom in this calcium. You can understand that this calcium is in the roof of the bifurcation. You can even rotate this geometry. You can remove the calcium, put the calcium back again to understand how that would play in terms of plaque modification, where are the side branches, etc. And I think this is quite of an important element. Now, when you think about pressure losses, you need to have a step in the curve in order to the flow to increase with PCI. In this particular case, you see here that, yes, the distal part of the vessel is red. It means that it's bad, the flow is low, but there is no real translational pressure gradient. If you look at this in kind of what we're used to see, this pullback curve, you'll see here that despite this appearance to be to kind of a small translational pressure gradient, the rest of the vessel is quite diffuse. And here you get a PPG, which is fairly low, 42. And the problem with these cases is no matter what you do, and this case was treated with PCI, I don't have the time to show you, it was a complex PCI in this particular case because there were 3 stents implanted. But what I want to show you is that when in absence of translational pressure gradients, PCI does not improve flow significantly. Look at this case. So the flow in the distal part of the LAD is 68%, or the FFR 0.68. Then if you want to treat kind of the lesion, which is here at the level of the bifurcation, distal to the side branch, with a 26 millimeter stent, basically you don't get any improvement in physiology, or you get 5% improvement in flow, which is basically nothing. If you extend this and then you try to treat kind of from normal to normal from that proxial AD that has some disease, the improvement in flow is very, very low. And the reason is there was no translational pressure gradient there before. So I think that in bifurcation lesions, we need to kind of be sure that engaging into that procedure will derive benefit in terms of improvement in flow, which is basically the driver of improvement in symptoms by reduction in ischemia. And this can be looked at either by CT or basically just with invasive physiology, doing an FFR or a resting pullback, you'll get the same information. Now, I don't want to go in depth into this concept, but we have validated already that in cases of diffuse pressure losses, I'm talking about physiology, when you have this PPG that is in the horizontal axis and is low, you can do imaging guided PCI, but you will not improve the flow. In contrast, when you have these big steps in the curve where the PPG is high, you get large increase in flow, and those are the patients that actually do better with PCI. And again, this number here on the right means that half of the improvement in blood flow depends on the disease of that particular vessel, which is something that we didn't know before. Now, this is before, and again, I think that we have randomized a little bit more than 1,100 patients. We have concluded recruitment. Everything went, well, I think, I don't know what the results are going to be, but what we have learned so far just justify the whole endeavor of the trial, where basically we randomized this patient with severe lesions to be, after centralized screening, to undergo what we call CT-guided PCI or IVUS-guided PCI with mandatory pre and post PCI imaging and defined imaging endpoints. This was a non-inferiority trial. The primary endpoint you see it on the slide, and then we have a number of key secondary endpoints which are pretty interesting to look at. Now, what is this CT-guided PCI? Because that's going to be the next kind of question. How do we kind of mimic what was done in the trial? Well, this was very comprehensive. This was a mandatory revision of what we call a planning package that involved, one, the assessment of the disease complexity, the selection of the guiding catheter for tailored support, the understanding of the calcium severity and the need of plaque modification, the mass at risk that, again, in bifurcation lesions became essential, the model embedded in the lab for the selection of the best projection, and full use of physiology. Physiology as it is in the guidelines today, which is the positive and negative physiology for determining significant and non-significant lesions, but also physiology in this new way of looking at lesions. So how much was the transitional pressure gradient? What was the theoretical impact of that vessel after putting a stent? And this is, again, CT-guided PCI. I want to start thanking and congratulating all the sites of the study. These are all the sites that participated in before. As you have seen, we have sites from all over the world, in Italy, in Belgium, the UK, and France, United States, and even Japan, and in Denmark, of course. And you see here, these are organized actually by the number of patients recruited. So in that order, I would like to thank all of these investigators for the big effort in a trial where we recruited before the planned recruitment, which was kind of remarkable. So in bifurcation lesions, the use of CT for PCI planning offers a number of advantages, and that includes the classical understanding of the bifurcation geometry with the calcification for the bifurcation angle, but also the plaque distribution and the plaque location within the bifurcation. I think that this 3D aspect is key. The second point is the mass at risk. Quantifying the mass at risk with a number, I think that complements the decision-making process in a way that is reproducible and is quantifiable, and I think it will offer a way of standardizing procedures in the future. And I truly believe that the incorporation of physiology in bifurcation lesions will be helping us understand where PCI is of its highest benefit and avoid treatment of bifurcation lesions that will not improve and do not require PCI when we think about this translational pressure gradient. Thank you very much for your attention, and enjoy the rest of the meeting. Thank you very much.
So that was recorded. I mean, it's the most complete presentation. I mean, I've seen many, many of them. And I think what is very interesting for the young interventional cardiologists which are in the room, Carlos Collet was originally from Venezuela. Then he moved to Eduardo Souza in Brazil, and then he came to Rotterdam. Has never seen a multi-slice CT scan, was trained by his mentor, Yoshinobu, who was trained in multi-slice CT scan. And then you see in Rotterdam this extraordinary evolution because he moved to Aalst, he continued, and now he's in New York in the CRF. And I can tell you, I don't see the end of this progression. But what is going to happen is that at one point, we will use that technique, yeah? Because you have one single evaluation, non-invasive imaging, and wait for the presentation of Filippo Cademartiri, and then you can really make a lot of interpretation. We'll see, we'll see. But I think the 4P trial is a very important trial. There's no doubt about that. You must have the gut to do that and have this huge worldwide network to do it. Okay, we go to the next, also remote presentation by Filippo Cademartiri. Filippo is also somebody who was in Rotterdam for a long time, 25 years ago. I like it very much. And then about 2 years ago, I realized that he had the photo counting in his institution. He's between Naples and Milano, and the image that he has is absolutely spectacular. I think it's a recording, no?
Hello everyone, this is Filippo Cademartiri. Thank you for the invitation to give this presentation, and I apologize for not being there for personal reasons. Today I will talk about photon counting CT and the left main stem. These are my disclosures. This is the first image published in vivo in a patient on a main journal, and it was actually a left main and LED stent with instant restenosis. It was 2022. This technology has been developed now for 20 years, but photon counting became real only in 2021, actually, so 4 years ago, and it expands further the galaxy of cardiac CT with several new applications. What is photon counting? Photon counting, in very simple words, it's a new kind of detector that allows to skip some steps of the conversion of the signal. So the photons, instead of coming into the detector and being translated in several ways and coming all together on the detector elements, they can come into the detector, but they can be detected, counted directly, and each photon can be weighted on its own features, and it can be separated. So all photons are counted and separated from each other. This leads us to the possibility of eliminating electronic noise, the possibility to use much smaller detector pixel, the fact that at lower energies have the same performance of higher energies. There is always the possibility to perform spectral imaging, and there is what I said, so this direct conversion. The result from the technical standpoint is an extremely high spatial resolution in the range of 100 microns, the possibility to perform functional and perfusion imaging, the possibility to have a X-ray spectroscopic imaging, and also it opens the possibility for molecular imaging. Several other companies, now only Siemens have a photon counting CT scanner, but other companies are going to come next year, most likely, and we are all very curious to see what's going to come. So for the left main, anatomy is very important. The possibility to measure the size of the vessel, the size of the lumen, the area of the lumen, and also the plaque morphology is very important for the planning of the procedure, but it is also very useful to have a technology able to provide a very, very accurate visualization of the stent itself, so the patency, the positioning, the overlapping, and all the features in the follow-up. So what is the performance of photon counting CT? This is the performance. You see a cross-section of the proximal LAD over here with a standard detector, and here with a photon counting CT. So the resolution, the spatial and contrast resolution are very much improved with photon counting. It's a really giant leap for the imaging technique. And some signs are improved. We have a new semiology. In this case, it's some intimal irregularities within the coronaries. We couldn't see actually these kind of alterations before. And also ulcerations. Ulceration like this one in this proximal LAD. And we can tell that this is actually an ulceration of the wall of the artery. And this is another example in a very diseased LAD with another ulceration and a corresponding invasive angiography images. So stents, we can see stents, but now we can really see very well inside stents. Actually, there is no problem in looking at stents like if they are standard coronaries. This is an example of mild intimal hyperplasia, and this is an example of significant in-stent restenosis in this full metal jacket of the right coronary. So what about left main? Left main is a very delicate area, and in this case we have a stenosis of the ostial left main, and then there is another stenosis, milder stenosis at the level of the ostial LAD. Both plaques are non-calcified. There is a kind of negative remodeling, and it's very easy to have a very clear depiction of the contours of the lumen and of the plaque. This is another example of a stenosis of the left main. This is more the body of the left main, and then there is this trifurcation with LAD, intermediate branch, and circumflex. And on this particular images, we can have, of course, any plane we want. We can rotate, we can twist, we can change whatever we want, and we can, of course, measure the actual size, the area and the diameters of the reference diameter and the stenosis, and make the calculations, and of course also of the target vessels, the distal vessels, like in this case the LAD, the intermediate branch, or the circumflex. This is another example where we have a stenosis at the level of the ostium of the left main, just after the ostium, and there is another stenosis in the distal left main that involves also the ostium of the LAD. And for each and every one of these stenosis, we can have the perfect calculations and also all the areas that we need to make our assessments. And the follow-up, now I will go through many examples. This is a left main LAD. As you can see, there is nothing. There is a large plaque outside, but there is nothing inside the stent, as it is for this other stent, left main LAD. Very easy to see the patency, and also very easy to assess the calcification at the level of the ostium of the circumflex around the stent. Another left main LAD, again the ostium of the circumflex over here, no problem in assessing the patency of the lumen. In this example we have left main and a long LAD stent, but in this case we have in-stent restenosis a bit more distally here at the level of the middle LAD stent. There are 2 points with in-stent restenosis here. They are not critical, they are not very severe, but they are there. Another very large left main and LAD proximal and middle without any problem in assessing the entire lumen. Another left main and proximal LAD. This is more complex because the patient was very, very large, and there is an occlusion of the ostial intermediate branch due to the plaque shifting at that level. Another very complex example, in this case there is another trifurcation, and there is a patent stent with some disease immediately after, but there is also a circumflex with a lot of disease in the proximal part. So in conclusion, as some very important authors stated, the future of this kind of imaging is photon counting. Photon counting will be the first and the go-to imaging modality for most of the applications, especially when anatomy is important. Every patient will get a photon counting CT, and we will use these images really to plan and to follow up every application. Thank you for the attention.
So I think that the audience, yeah, sure, the audience will understand my excitement 2 years ago when I saw these pictures. And not so long ago, I was with Yves and Goran in Belgrado, and I had the coronary revascularization 2040, yeah, which is coming in the European Heart Journal. And you remember that on one slide I said the photo counting will accelerate the disappearance of the diagnostic coronary angiogram. I'm convinced of that. And it will go probably faster than we believe, because there are above 300 of these photo counting now. China is coming with a remarkable United Imaging, very high quality. GE is coming, everybody is coming with this technique. So our generation will see the disappearance of the diagnostic angiography. One point has to be said very seriously: we cardiologists has to work with the radiologist, have to learn the technique, have to have his own analysis. Otherwise, the radiologist can become the gatekeeper. I'm a GP, I have a patient with angina pectoris. I'm not going to ask anymore an exercise testing of a PET office. No, I will send the patient to the radiologist. We'll do all these things that we have seen, not tomorrow, but the day after. That's the real danger for the cardiologist and for the interventional cardiologist, because at some moment, the radiologist said, I'm so educated, that patient should not go to surgery, should not go to PCI, should have prevention. That was my introduction with 3 anecdotes. That's what is. Giulio, you want to say something?
Yes.
Oops.
Thank you. I think that everybody saw how much we can be excited, but also how much we needed to work on this technology. It's digital. Everybody saw the pixel of each imaging. And perhaps we are going to get a new type of variables from the 3D, voxel, name that we never heard, instead to go for a cross-sectional view. So I think that the margin, the potential margin of amelioration are a lot. AI can work additionally in making much easier the digestion of these very clear images. That is what I'm expecting in terms of vision.
Yeah, I mean, I think I showed again in Belgrado and other places with the hierarchical contrast phase CT, the voxel is now 2.3 micron, 2.3 micron, okay? That's still for only a heart which is post-mortem, but the whole destructive dissection of the anatomopathology is no longer necessary. That will also disappear, you know, the fact that you cut the heart in piece. Yeah, there was a question there. Yeah.
Small comment. I mean, I think it's important to integrate the physiology from the CT, because what struck me from Cademartiri's presentation, all of these cases were treated with extremely long stents, sort of full metal jackets, probably based on the anatomical features seen on the CT going from normal to normal. And that's probably something that we want to avoid.
Yeah, but you know, you remember the curve, the PPGI curve of Carlos Collet. You cannot put a stent in that. Either you put 80 millimeter and you will not improve the FFR. So basically, that's where the drug coating balloon could do something. It can partially enlarge the vessel, even if you have to do more than 1 times, okay? Because the surgeon putting a bypass distal to this QFR who goes like this is not useful. I mean, we have already some evidence of that. So what you say is very important. It's not only, you should not think stent, you should also think drug-coating balloon and other things, yeah? We go? You go. Yeah. You go?
I go. So the next presentation will be CT hologram of the main stem, gadget or useful virtual reality. I like this title. So, Tsung-Ying Tsai. Dr. Tsai is in the room.
Hello everyone, it's my pleasure to present my talk, CT Hologram of the Main Stem, Gadget or Useful Virtual Reality. I'm Tsung-Ying Tsai from the University of Galway. So let's start with what is hologram. So the hologram is a three-dimensional imaging that's created through the interference of light beam. It can be from laser or from other sources to make it feel like an optical object that can be viewed and manipulated in the real space. It is especially suitable for complex, three-dimensional, moving, or layered structures. In the medical field, it has potential to be used for medical education, procedure or surgical planning, procedure guidance, as well as patient education and rehabilitation. Then, if hologram is so useful, how do you bring it into the reality? The answer lies in the extended reality technology. The extended reality is an umbrella term for all the technologies that produce all immersive technology that merge virtual and physical experiences. You can have the very immersive virtual reality technology that best example recently is the Apple Vision Pro. And if you turn on the transparent mode of the Apple Vision Pro, you get mixed reality where you can still see 3D object, virtual object, while you can still see the surrounding. The augmented reality provides less information but more interactive, almost not interfering with your view. The most recent example is the recently announced Meta Ray-Ban display. So in the medical field, as well as in the cardiovascular field, where is the evidence? So in 2024, we did a systemic review for all the publication until July, and we found 164 such studies included in our meta-analysis. It ranged from medical education, training, planning and procedure guidance, as well as planning aftercare. It encompassed structural heart disease 35 studies, congenital heart disease 28 studies, electrophysiology, as well as cardiac pacing, and cardiac rehabilitations. But what about complex CAD, which is the topic of today? In 2022, during the conduction of the Fast Track CAPIT trial, which is the first study that used CCTA as the sole guidance for complex CAD revascularization with CABG surgery, we did what we call a heart team new style. In this, we use the 3D hologram, and to visualize the anatomy, we measured the length, the distance from the intrathoracic artery, and measure the distance between the different anastomosis, and measure the three-dimensional curved distance for the graft required, and we validate our measurement afterward. And what about PCI? So this study done by the Swedish group, they conduct 10 pilot cases with remote proctoring for CTO procedure. Here, the doctor in the remote hospital is able to receive direct guidance from the proctor 260 kilometers away, who can share his view and view the clinical data with very little lag, and to directly guide him complete 10 complex CTO PCI cases. And what about during the procedure? In this case example, as published recently by the National Taiwan University Hospital, 5 patients were successfully recanalized during the CTO procedure, during which the operator is able to not just see the cardiac anatomy segmented, but also the coronary artery segmented. It is important because during CTO, the distal vascular target is not necessarily visible on the coronary angiography, but on CT, it's frequently visible. So what about left main PCI, the topic of EBC? In 2023, we present the CCTA intravascular imaging guidance in a very interesting left main PCI case. In that case, we produce this left main PCI strategy pre-procedure just with CCTA alone. Can mixed reality bring any better than this? Let's take another look. In this example, we use the same CT data, but we load it into the hologram software. As you can see, I can visualize the distribution and the trajectory of the coronary artery. And also when I cut the hologram, I can see the inside of the ascending aorta. And when I rotate it, I can see the sinus of Valsalva, and I can call a clipper, and I can measure the distance between the left main and the other side of sinus of Valsalva. So I know I need a 3 EBU catheter to be the guiding catheter. And also because the angiography angle is provided in the hologram software, I can also plan my angiography angle. I don't need an FFRct to do that. And what about plaque? In this case, we carefully measure the plaque with the MEDIS software. And after I load it into the hologram software, I can see the plaque on top of the hologram. The lumen is in gray, the lipid plaque is in red, the fibrofatty is in yellow, the fibrous is in green. I can also toggle the window to see just the contrast, or just only look at the coronary tree at all. And I can toggle different type of plaque. Here I am toggle off all the other plaque type to just see the coronary calcium. Now I see only the calcium. I see there is a huge chunk of calcium located from the left main to the left main bifurcation, and I need a plaque modification with lithotripsy to deal with that. Now, after viewing that, I can see the other plaque type, the fibrofatty in yellow, the fibrous in green, the necrotic core, the lipid plaque in red. So I see a lot of lipid plaque in the proximal AAD, so I need to put my stand over it. And I can land in somewhere with green, that's probably safer. And I can start the measurement in 3D, in curvature, and I can do whatever I want just to know on site, online, how long the stand is going to be. And then I can also visualize the physiology. Note that the color here is in reverse. It is not the right way to show the FFRct, but if you just imagine the other way, the FFRct can be viewed at the same time when you are visualizing the anatomy. How about like after you perform the PCI, after you pre-dilate, actually the hologram software can receive the data output from the OCT software, so you can load it with some minimal lag into the hologram software so that you no longer see things on the 2D screen. You can visualize the 3D structure of the OCT in front of you. And better yet, after the adjustment, you can make direct measurement on this OCT hologram, which is very accurate when compared with the direct measurement on the OCT platform. So this is how we imagine the future of the cath lab could be if the expert at the EBC would like to develop it. You have simultaneously the fluoroscopy, the CT with the plaque information, with the VR, where you can cut, measure, rotate, and also you could have the physiology information on the coronary CT as well as the as well as the three-dimensional information from the OCT. If you look at the right lower hand side, you will find that the operator keeps his hand in the mid-air so that he doesn't break his sterility, so he can keep operating while manipulating the hologram. So CT hologram, is it useful or a gadget? It depends so really on the experts. But for the left main, the anatomy is complex, the stakes are high, and there's a lot of information that could bring cognitive burden to the operator. And combined with the 3D printing, computer simulation, and bench testing, the 3D segmentation and hologram could be a very powerful tool that will improve the quality of procedure for left main intervention. Thank you.
So, Yves, 74 years old,
yeah.
Correct? I'm 78, so I'm older than him. But I think that the reaction of the audience could be, this is futuristic, this is not for me, I will never go in that direction, and that will be a big mistake. Yeah. Because I really believe, you know, that you have, as a physician, remain curious about the future. And that's a great motivation. And of course, it's at some point is an investment, but I think it's an investment which will pay off. I'm not talking specifically about the hologram of the virtual reality, but the first part of the meeting with Carlos, Collet, Yoshi, and Filippo really convinced me that it's going to take place. I have no doubt about that, absolutely no doubt. And that's the reason why 2 years ago, the European Society asked me to talk about 2040. And that was a real challenge to say what is going to happen 2040. But it's a good exercise in curiosity to say, what are we going to see? And I'm sure that one day we will come back to the EBC and we will have sessions which will be only that. I remember when I came to the ABC with the first OCT. You know, that's 2008.
Yeah.
Okay, it was in a parallel session. People said, "Okay, nice pictures, but I don't know. I'll never use that. I'll never use that." And it takes basically 20 years to get there. Yeah, and to see pictures. So it will come. Any question that I could respond, that Yoshi could respond, that somebody in the panel can respond?
Sorry. I just want
put the microphone here.
Yeah, but it's not working. So I just wanted to ask, in your opinion, what are the obstacles that we need to overcome to reach this reality, like in everyday practice? I mean, is it just money, the availability of these CT scans, which we have seen, this photon counting, or just the mindset, which we don't have yet?
You raise a very important question that I've been dealing with for a long, long time. There is two aspects. You have to work in a milieu who is interested by the future. That's point number one. There are a large number of people who are conservative by nature. Okay, that's for somebody in training. Now, financially, it's also a major issue. Photo counting is 3 million, okay? If you go to Germany, and I've been talking with a lot of physicians in Germany, they said, my source of revenue is diagnostic and geography, and I will never abandon that, period. A la German, you know? And I think these people is wrong, because the reality is you have to do something which is more friendly for the patient in the first place. You need a better preparation when you go to the cath lab. You know what you are going to face. You know, a main stem lesion osteo that you don't know. You ask the fellow to do the catheterization because you don't know that's the left main. You kill the patient. I have seen that. You kill the patient. And discharge, the big result of discharge, CTA before whatever, diagnostic angiography of intervention, the whole benefit of 64% is in the first 48 hours, is a reduction of complication of catheterization and procedure.
Again, of money is FFR, IVUS, OCT.
You know, I can tell you, you have seen in Belgrado these pictures of the hierarchical contrast phase CT. At some point, we will have a resolution which will be close to the OCT. I think that the intravascular has to be targeted. I think that in the first place, when you have your diagnostic multi-slide CT scan, you can say to Giulio, we should look at that lesion in terms of OCT IVUS. It will be much more direct than sometimes this long trajectory where in the lab you analyze that very superficially because the physician has no time. He's not going to measure the thickness of the cap and this and that. So at some point there could be a competition ultimately between the intravascular and the non-invasive imaging. It will be some kind of competition. I'm curious to see what's going to happen because we are not there to multiply the examination. You know, when we see when we do, and we have done that, an overview of the test in patient before going to the cath lab, it's amazing. It starts by an exercise testing, which is so-so. You go to a thallium scintigraphy, which is so-so. You do a dobutamine stress so-so, and finally say, let's do a catheterization. That's redundant. For the healthcare, it's very expensive. So we have to try to do a medicine which is really targeted. And you can use an OCT and an IVUS when you know what you are looking for. Is that an answer? Yeah?
So I think I'm coming back to your 3 anecdotes of this morning. The most impactful is the first, is a therapy recommendation with an explosive growth of this non-invasive imaging and a very accurate application of segmentation, plaque detection, and so on. So I think that the therapy recommendation can change the landscape. And that is going to save an incredible amount of money. Sure, and also in perspective for the different countries, it's going to be very important also for the poor country to invest in something that we call prevention, but we never have.
No, I think that I always split the population in 2, the elderly and the younger. The young who have soft lesion, basically with the omics and the imaging, you will detect at a very young age the abnormality. We have to go, right? Yeah.
So the last lecture will be by Shengxian Tu, the integration of CCTA and angiography for assessing the perfusion of coronary branches. So in the topic.
Thank you, Chairman. Dear colleagues, it's my privilege to be here. Thanks for the invitation. So today I would like to present a concept I've been working on for several years, and it's still ongoing project, so I hope that it's giving a concept. So I come from Shanghai. This is my disclosure. So we developed this CT software called CTA Plus that allows automatic analysis of coronary plaque and also the CT MUFR on site. So this could be done very fast now, within 2 minutes. And the latest version also included the quantification of the myocardium mass at every position of the vessel and every branch. So this video shows you that if you move the position, you can see the color change indicate this is the reason that distal to this position, how much myocardium mass is influenced. And you can quantify every branch, every position, including left myocardial mass and right myocardial mass. So now you get the myocardial mass. The next step, you co-register with angiogram. So this is a technology that we present this year at EuroPCR. As you can see that the position in angiogram and CT are synchronized. So you can pinpoint at every angiographic location and then quantify the myocardial mass of this location. At the same time, all the plaque information is overlaid on the angiogram. And this is useful to place the landing zone for your stent. And because you can see the plaque information very intuitively on angiogram. White is calcium, and orange is lipid, and fibrous is green. You also do the physiology, CT MFR there, and you can also do virtual stenting. So this has been demonstrated in a live case, it's a real live case in EuroPCR this year. So by Javier Skenet in the main arena. So this is based on an artificial intelligence algorithm called graphical vessel matching. So this is a network that we developed to mimic how human being do the correlation between CT and angiogram. And it's published in the IEEE, so it's the top medical imaging journal, technical journal. As you can see that the algorithm outperforms all the state-of-art correlation algorithm, and it's done automatically without any user interaction. And it can also work for CTO. So this is another live case we recently performed in China. As you can see, angiogram, you don't see the distal segment, but CT, you can still see them, and you can reconstruct them, all the plaque information, distal to the obstructive segment. In this case, you can see proximal to the CTO side, a lot of calcium there, but after that, very minus calcium, so you can anticipate the resistance of the wire if you want to do CTO from here. Now with the CT myocardial mass and the correlation, next step is to get the flow. So this is the new AI algorithm that automatically tracing the contrast dye in every branch and then quantify the volumetric flow from a single angiographic run. You need the optimal projection, for example, LAD, right coronary artery, circumflex. We select one of the good projection and quantify the volumetric flow from AI automatically. If you do record the resting angiogram, you can quantify the resting volumetric flow. If you do hyperlimic flow recording, you can quantify the hyperlimic flow, and as well as their resistance at resting and hyperlimia. You can also use them, both of them, the two, one in rest and one hyperlimia, to calculate the CFR and also the MRR. In this case, the aorta pressure did not change after inducing hyperlimia, so you get the same CFR and MRR value in this case. So in order to test the feasibility, we performed a small study, 21 patients with a slow flow phenomenon, and recently published. As you can see in this protocol, so we make one resting view first, and then give nitro, and then make second angiogram, and we induce adenosine by intracoronary, and make another, the third angiogram. And then we wait 5 minutes, so without doing anything, and then we make another resting flow projection, and to see whether the resting flow can be reproducible or not. And then in the end, we give nigrorandio and then make another hyperlimic projection. So we can calculate the resting flow and 3 hyperlimic flow. And using the first resting flow, we can obtain the CFR by different drug, and then we can change to second resting flow and see how the impact. These are the main results. As you can see that different vasodilator, including nitro, has an important influence on the flow, substantially improved compared to the resting flow. And if you have your second resting flow occur after 5 minutes without doing anything, then you can see that can be reproducible. So if you can use them to calculate CFR, it's similar, the value is similar compared to if you use the first resting flow. And surprisingly, the nitro has a almost similar effect on patients with slow flow compared to the adenosine in our observation in this small study. So more study on the volumetric flow measurement is still ongoing. Now, you have the volumetric flow of the angio and correlation with CT myocardial mass. Now you can use the combination to quantify the myocardial blood flow as indicated by this formula. So this is a case that in our study, that is still ongoing validation study. This is a case the patient has angina. So the CT perfusion shows some defect here. As you can see, the angiogram was performed. We did not see much obstruction or stenosis there. But if you quantify the resistance, volumetric resistance, by angiogram, you see high resistance. And also if you quantify the perfusion, so compared to right coronary artery, the perfusion is much less in the LAD and circumflex vessel. So this is still ongoing validation. Hope next year I can present the result here. Ladies and gentlemen, in conclusion, AI enable on-site quantification of myocardial mass per coronary segment from CCTA and accurate correlation with invasive coronary angiography. Automatic computation of volumetric blood flow from a single angiographic view is feasible, and the computation is reproducible when angiogram is acquired following standardized protocol. And the combination of conventional CCTA and coronary angiography allows quantification of myocardial blood flow and has potential in identifying ischemia in patients undergoing conventional CCTA and coronary angiography. And thank you for your attention.
Shengxian, I'm sorry, we are very late, so we'll skip the discussion, but you may discuss with Shengxian during the lunch coming.
Okay.
So we end this session now. Just a word coming from me. I was doing for 15 years, I was doing cardiac MRI, and 10 years I was doing CT scan, and the lady who replaced me in Massy is in the room, Francesca, and she is doing also MRI and CT scan. So I think this is for the young operator in this room. You have to think about conversion to this non-invasive diagnosis.